Thank you, Dr. Muhammad, for this nice presentation. Now it is my pleasure to introduce my dearest colleague, Professor Mosaad Sulliman, who will talk about arteriovenous malformation, the non-equipoise battle.
Thank you. Yes, it's a battle of a vascular malformation, which constitutes one of the most enigmatic problems in the history of medicine, both in the diagnosis and treatment, either endovascular or by surgical means. These are the results of defects during birth, constituting a communication between different sized arteries at the veins, resulting in a reticular network of dysplastic vessels that fail to form a capillaries but forms a nidus. So, in all the nosology, we failed to have a better classification in order to make a precise diagnosis, evaluation, and implementation of therapy, like the old terms we used to use, like the Klippel-Trenaunay and Barks-Weber syndrome. So we have many other classifications, like the Hamburg classification, which demanded the predominant lesion, whether it is infiltrating or limited, localized, superficial, or deep, and the ESVA classification counting the vascular malformations and the vascular tumors, making a high flow and low flow, and lastly, the Yakis classification. All the other classifications failed to implement a kind of therapy. For the X classification, it helps in definition of a line of therapy, like in type 1, you have 3 vessels in a single venous channel, and type 2, more than 3 vessels in a single venous channel. Type 3, A and B, having multiple arteriolar and venular communications that differs during the angiography, either as a plush in type 3A or as a mixed plexiform vascular malformation in type 3B. But in this kind of therapy, we are able to handle how we can treat or tackle the lesions. Like in type 1, you can attack the venous channel, and type 2, you can attack the venous channel. In type 3 and 4, you can attack either the arterial only, and in type 3B, you can attack the arterial, venous, or in between through direct tackling of the nidus. So, in all these kinds of classifications, like the Spinger classification about the quiescence and the behavior of the lesion, whether it is aggressive or quiescent, and we have the real battle between the ill-planned and improper surgical strategy. This, like making an incomplete resection, ligation, or proximal embolization of the lesions, and the backfire would be the result of over-aggression of the lesion and the recurrence of the lesion by recruitment of the vessels and new vasculature. So, in such a case, we had large lesion, surgical excision alone, very good results, but a few years later, we have everything aggression again. Again, for the surgical excision of such lesions, and the recurrence is very high. So, can you count on sclerotherapy as an independent surgical therapy? Yes, for surgically inaccessible lesions, and the lesions extending beyond the deep fascia into the muscles, and you can use multiple accesses through arterial, venous, or direct puncture of the nidus using the BVA or the polyvinyl alcohol particles, the microspheres, the gel foam, or the avitine collagen powders. But again, the problem is that you may have these particulate agents either too large to occlude the main feeder with recurrence, or too small to cross the nidus and inducing a non-target vessel embolization with catastrophic results. In this photos, you can see multiple lesions affecting multiple areas, and after microsphere embolization, we have a great results and improvement of all sides. On the other hand, we have such a kind of lesion affecting the tongue and the lip, and with intervention, you can totally ablate the lesion sequence and every time, and you can repeat the procedure as it is minimally invasive. You can repeat as much as you can. And such lesions, extensive lesion affecting the tongue and the lip, and the total ablation of the lip of the lesions on the right-hand image. again, we have a problem like affecting a diffuse area of the lip and cheek, and after embolization, total ablation of the lesions is done. But what we have a non-target embolization to the retinal arteries through the extracranial, intracranial communications, leading to a loss of sight on one eye. This is a catastrophe. Again, we can use other materials like the coils, but coils is applicable and adaptable only for large vessel occlusion feeding without affection of the nidus. So the feedback or the fireback will be again recruitment and recurrence of the lesions. You can use as much coils as you can. You can use in any accessible sites, and you can have such a very nice images of large lesions like in the upper arm. You can use a liquid agents. Liquid agents are having many advantages like reaching the nidus, diffuse occlusion, intimal damage in an extirpating way. We have two types like the sclerosants and the polymerizing agents. Ethanol, sodium tetradecyl polydecanol, and pleomycin. And ethanol is the most commonly advised one for the arterial side, while the others can be used for the venous side. On the other hand, we have polymerizing agents like the onyx and the cyanoacrylate. Onyx, which is a copolymer epicillin and vinyl alcohol, dissolved in DMSO or the dimethyl sulfoxide, and it has many advantages over the N-butyl cyanoacrylate by being slowly adhesive, less adhesive, and slowly polymerizing, giving you a longer time for application rather than the N-butyl cyanoacrylate. This is for extensive lesion affecting the face. Onyx can be applied several sessions, many times, complementary therapy later on. Can we do the preoperative embolization and then doing a surgical intervention? Yes, you can do that, especially for large lesions to control inaccessible arteries, reduce the surgical blood loss, shorten surgical procedure, and increase the probability of total resection of the lesions. Lesions with embolization followed by surgical excision, safe. Again, lesions with pre-embolization and then is followed by surgical excision. Again, for large lesions affecting a diffuse area, multiple embolization several times and then surgical excision, and you will have a very improvement. Again, you can do extracranial embolization of large lesions. But what if the parents refused to have this intervention? This is Joseph. Joseph was being discovered at 3 months, and his parents regret toward doing anything, and they left him. So we followed him up to see what is going to happen, and this is what happened. So shall we intervene, or shall we just wait and see such like cases extending day and day? So in the light of the relatively high complication rates, with all intervention procedures, careful patient selection is a paramount importance. And again, general guidelines should be agreed upon well in advance, and patient selection should be tailored according to every clinical situation. Thank you very much.
Thank you very much, Dr. Mosaad Sulliman.